Hello, everybody. Today we're going to talk about outbreak investigation. This is a very relevant topic nowadays, and it will help us try to understand the different steps of outbreak investigation and how we go about doing that. So let's first talk about disease occurrence in population. There are different ways of describing disease occurrence. It could be what we call sporadic, which means that there are occasional cases occurring at irregular intervals. Here and there, the disease is popping up. It can be endemic, meaning that there is always a baseline number of cases, a continuous occurrence at an expected frequency, a baseline number of cases that is occurring at all times, and this is what we call the endemic level. Now, when we say that there is an epidemic or an outbreak, it means that the occurrence is higher than what is expected. So you have a certain number of endemic cases that you expect, and then during the epidemic, you find that the number of cases is higher than what you expected, and this is what we call an epidemic. When you have a pandemic like what we are experiencing right now, it's an epidemic that involves several countries or continents and affects a large population. So here is a graphic description. Uh, Here you can see this is what we call an endemic disease. There is always a baseline number of cases that are occurring. When you have sporadic, it means that there is no baseline cases, but sometimes you have here and there, you have some cases occurring, and that's what we call sporadic. An epidemic is when you have in a very large number of cases occurring at the same time in a particular area that exceeds the baseline that is expected. And then the pandemic, it's when you have multiple outbreaks everywhere occurring over a large geographical area. Again, this is the baseline in blue. This is the baseline rate. In purple, it's the actual numbers that fluctuates, but the general number, the mean number is in blue. Whereas over here, you can see that in red, you have a spike in the number of cases. And this is an epidemic. And then you go back to baseline to the endemic level. And then you have another spike or another epidemic. And this is another way of showing it, the endemic level and then an epidemic component to it. Now, what causes incidence to increase? This is a familiar slide to you, it should be, because this is the chain of infection that we saw in the first lecture that I gave you, that includes the infectious agent, the reservoir, the portal of exit, the mode of transmission, the portal of entry, and the susceptible host. And the incidence can increase because of increase in mode of transmission, increase in the reservoir, increase in the infectious agent, increase in the susceptibility of the host. Increased mode of transmission, meaning that there is more contact between people, and for example, this results in enhanced transmission, person-to-person transmission. Increased reservoir, for example, there is a contaminated water source that behaves as a reservoir. An increase in the infectious agent, sometimes you have a new infectious agent, and sometimes you have an increased fitness of an infectious agent that becomes more and more likely to cause a pandemic. An increase in the susceptible host, if you have an increase in the number of malnourished people, an increase in the number of immunosuppressed population, etc. What are the factors influencing disease transmission? These are related to animals, for example, the environment, vectors, and the human being. All of them, they affect the agent of disease. So, for example, population growth, migration, and human behavior has a very important effect. And it also affects food production, intensive farming, using antibiotics in animal farming, etc. And then climate change, megacities, and pollution, as we are seeing right now, also affects animals and animal farming. And affects vectors, because if you have increase in the temperature, then you can have proliferation of some of the vectors, which makes the disease that is borne by the vector more likely to become. So you have vector proliferation and vector resistance. At the same time, when you have that, this results in increased infectivity, pathogenicity, virulence, immunogenicity, and antigenic stability of the agent. Now, this is a concept that I'd like you to know. It's the reproduction number. I'm sure that you've heard about it a lot nowadays. And it's basically illustrates the potential of an infectious disease to spread in a population. And it's dependent on 4 factors. First one is how long a particular patient is infectious or is contagious to other. Is it 1 day? Is it 5 days? Is it 15 days? It also depends on the infectiousness of the organism. How probable is the transmission in a contact between an individual patient and a susceptible one? So this is related to the organism itself. And the third component is frequency of contacts in the population and contact patterns in a society. How much do you have mobility? How much do you have people contacts? This is the third factor. And then the fourth factor is how big the proportion of the population that is already immune and not susceptible. Because the larger the population proportion that is immune, the less the likelihood of transmission. So these are the 4 factors that the reproduction number depends on. How do we calculate the reproduction number? The basic reproduction number, or R0, it is basically the average number of patients, of persons infected by a single disease source. So one person infected enters a room full of people. How many people in that room end up being infected? 2, 3, 15? This is the basic reproduction number. So how do we calculate it? If you remember the first 3 factors that we discussed in the previous slide, R0 is C times P times T. C being the number of contacts the infectious person makes per unit time. Okay. P is the probability of transmission per contact with the infectious person, meaning the infectiousness of the organism. And D, the duration that an infected person is infectious to others. And all of these 3 components we saw in the last slide as being the factors determining the reproduction number. So R0 is C times P times T. Whenever R0 is less than 1, the disease will disappear, meaning that every person will infect less than 1 person. If the R0 is equal to 1, then the disease will continue at a similar rate. It will not increase, but it will not go away. When the R0 becomes more than 1, then the disease will be able to spread. One person, if the R0 is 3, it means that one person infects 3. And each person of the 3 infects 3, that's 9. And the 9 will infect 27, etc., etc. And this is how a disease will be able to spread. So what we want is to decrease R0 by decreasing C, P, and D, and by causing then the R0 to drop below 1. So for example, when we decrease C by lockdown, then we decrease R0. When we decrease D by frequent testing and determining which patients are infected and asymptomatic and transmitting the organism, and we treat them, then we are decreasing D. Okay, so this is how we define R0. Now, what are examples of R0 of known infectious diseases? For diphtheria, for example, it's 6 to 7. For measles, it's much more, 12 to 18, and for pertussis, it's much more. For the COVID-19 that we are experiencing right now, people have spoken about 2.5 to 3. So each person will infect up to 3 people. Now, if you remember, there is a fourth component of the reproduction number, which is the population, how the proportion of the population that is susceptible. And by multiplying R0 with the proportion that is susceptible, you get what we call the effective reproduction number. So R0 is the basic reproduction number, and it assumes that all the population is fully susceptible. When you have R, it takes into account how much of the population is susceptible. The higher the proportion that is susceptible, the higher the R. The lower the proportion that is susceptible because of previous exposure or because of vaccination, the lower the R. So here you see an epidemic in susceptible population. One person infects 3 people. With immunity, the number of susceptible hosts starts to decline. So eventually there is insufficient susceptible hosts to maintain transmission, and when each infectious person infects less than 1 person, the epidemic dies out. Over here, the green circles are people who are now immune. So when the red circle encounters them, they like block the transmission, and the disease does not spread beyond them. It only spreads now to 1 person. So here the effective reproduction number, the basic reproduction number is 3, and the effective reproduction number is 1. So let's define what an outbreak is. What is an outbreak? An outbreak or an epidemic means that there are more cases of a particular disease than expected in a given area or among a specific group of people over a particular period of time. So we define them within a population, within a geographic area, and within a particular period of time. Whereas a cluster, it's just an aggregation of cases regardless of whether the number of cases is more than expected. So for example, if you expect a disease of like Salmonella typhi to occur around, you have 50 cases per year. If these 50 cases occur equally throughout the year, that's 50 cases per year, the total number. But if they, for example, cluster in one season and you have nothing in the winter but all of the cases come in the summer, this is a cluster, but it's not an epidemic because the total number of cases is still the same. How are outbreaks recognized? Outbreaks may be recognized because of a clinician that saw an increase in the number of a particular disease over a particular period of time, and they raise the alarm. Or it could be the infection control professional in a hospital. You know, in the hospital we carry out what we call surveillance, and we look for infections every day, especially in the intensive care unit. So whenever we find an increase in the number of cases, we try to investigate. It could be a lab worker that saw that there is an increase in the number of stool tests that are testing for Shigella, for example. You have many more cases of Shigella than what you would expect, and then they will also raise the alarm. It could be the patient or the patient's family. They tell you, we went to a restaurant, everybody we know got sick. It could be public health surveillance data, because some diseases are reportable. And the Ministry of Public Health collects all of these data. And if they see that over a period of time, the number of measles cases has increased, then they can recognize an outbreak. And of course, it could be the local media and the televisions, etc., that recognize the outbreak, but this is not what we want. We would like to recognize them much earlier. Why do we investigate outbreaks? We investigate outbreaks in order to prevent additional cases in the current outbreak. We want to stop the current outbreak. and we want also to prevent future outbreaks. But we also are able to learn about a new disease such as SARS or avian influenza or COVID-19. We also learn something new about an old disease like measles in immunized individuals. With the new outbreaks occurring of measles in immunized population, now we know more that maybe immunization wanes with time, wanes with age, and people become susceptible to measles once again in adulthood. We investigate outbreaks in order to reassure the public and to make sure that people know what they are at risk for, and they know how to behave in a particular epidemic and a particular outbreak. We would like to minimize economic and social disruption by stopping the current outbreak early, and we have the chance to teach epidemiology at the same time. Now, what are the steps in outbreak investigation? Outbreak investigation is a systematized process that goes through several steps in order to manage the outbreak and to prevent the future outbreaks as we would like to see. So there are multiple steps that we take, and I'm going to illustrate these steps with an example. Now, the example is a bit old, but it's nice. I'd like to keep it because it illustrates very well the concepts that we need to know with outbreak investigation. And this is a true story where in late June 1997, there were calls from 4 doctors reporting 6 patients with bloody diarrhea and E. coli 0157H7 infection. One day later, the Michigan Department of Community Health in the United States receives the call that there are multiple cases of 0157H7, an increase in the lab reports up to 52. So this is the initial alarm. So the first thing that we do, the first step in outbreak investigation, is to collect administrative data and to consult with experts in the field. So you have to prepare for the field work by investigating about past outbreaks, by looking for administrative support and technical support, and by consulting with experts in the field. The second step is to establish the existence of an outbreak. Is it true that there is an outbreak? Before we decide whether an outbreak exists, we must first determine what the expected or usual number of cases is for a given area and time. In order for me to decide whether this number that I'm seeing is higher than the normal, I need to know what the normal is. We also look at several factors that come into play, such as potential for spread, severity of illness, public concerns, etc. So in the example that we are talking about, these are the number of cases over a period of time, over the year preceding the current call. So in June 1996, July, August, etc., leading up to June 1997, these are the number of cases. So as you can see, there is a sharp increase in the number of cases in June of 1997. Is this enough to call this an outbreak? The answer is no. Because we need to study what could account. So in this example, they investigated and they found that there have been no substantial changes in population size and characteristics, and the lab protocols are still the same. The third step in outbreak investigation is to verify the diagnosis. So we have to make sure that we are dealing with the disease in question. We have to review the clinical findings, the lab results, and the epidemiological situation, the exposure history to animals, to humans, etc. So in this case, they examined the laboratory data and they found that 17 out of 19 isolates from June to July were indistinguishable by PFGE. And they did not match isolates from before May. So the number of cases that used to occur before May, they had a certain pulse field gel electrophoresis pattern, and now out of the 19 specimens that are new, 17 were new and indistinguishable. So we have dissemination of a single strain in this case. So then the fourth step would be to define and identify the cases. And this is what we call a case definition. A case definition is very important in outbreak investigation. And it is a standard set of criteria for deciding whether a person should be classified as having the disease under study. Okay? And in many outbreaks, we work out a case definition in order to permit the identification and the reporting of cases. The case definition will evolve as we know more about the disease and about the mode of transmission. So, for example, with the COVID-19 pandemic, in Lebanon, for example, our case definition at first was a person who has fever and cough and other respiratory symptoms, and having traveled to an area where there is a lot of cases, or having been in contact with a person who was positive. As the outbreak progressed, now we no longer require a travel history in order for the case definition to be fulfilled, because you have transmission locally, and you change the case definition based on the new data that you receive. So a case definition will include 4 components: clinical information about the disease, but also information about people, place, and time. Just like we said that the outbreak is defined by population, place, and time, the case definition is identified based on people, place, and time. We have 3 classifications of cases, depending on how certain we are about the diagnosis. It could be a suspected case, meaning that there are some typical clinical features, but not all. It could be a probable case, meaning that there are typical clinical features, but you have not had lab confirmation yet. Or it could be confirmed case if you have laboratory confirmation. So in our example, the outbreak investigation definition includes diarrhea, which is the clinical findings, more than 3 bowel movements per day and or abdominal cramps. Who are the people and where is the place? It's the resident of Michigan. What about time? It's the onset of symptoms between June 15 and July 15. And they also had to have a stool culture yielding the E. coli 0157H7 with the outbreak strain PFGE pattern. Because if you have the old one, it means that these cases will belong to the endemic rate, but not to the outbreak. So you have to have the outbreak PFGE pattern in order to classify a case within the outbreak. The 5th step in outbreak investigation is to describe and orient the data. And we describe them again with time, place, and person. We can describe the data by time, and we draw an epidemic curve by date of onset, and we will look at epidemic curves more later on in the following slides. We can describe the data by place, by geographic area, and what we saw at the beginning of the presentation with the geographical areas showing the endemicity, the sporadic cases, the epidemic, etc. This is what we call a spot map. And it allows us to distribute the case by geographic area. And you can describe the data based on person. You describe them based on age group, based on gender, on race, on occupation, etc. So let's talk more about the epidemic curve. How to set it up, what it tells you, the timing of exposure and the course of exposure. So basically, there are several modes of transmission. It could be a common source transmission or a propagated transmission. So let's look at each one of them. A common source outbreak means that there is a single shared or common source of or a reservoir that contains the organism, such as a batch of bad food. People go on a picnic and they have a bad jar of mayonnaise with them, and that serves as the common source of the outbreak. Or a contaminated water supply. Once you control the source, you stop the outbreak. Okay? So if you throw away the jar of mayonnaise, the outbreak goes away. Or you can have a propagated outbreak or a person-to-person spread, meaning that you have a disease that goes from one infected person to the other. So if you control the initial source, it is no longer sufficient to control the outbreak because the person himself or herself is serving as a reservoir to spread the infection. So how does an epidemic curve look for a common source outbreak? With a common source outbreak, it could be a point outbreak, meaning that all cases appear to occur within one incubation period. No person-to-person spread. You have exposure here, you have the incubation period, you start seeing the number of cases increase, and then it goes away, it dies out. This is what we call a common source point outbreak. One exposure, one incubation period, everybody gets sick and everybody gets well. No person-to-person spread in this case. And this is a short duration of exposure that did not persist over time. Examples of this include diarrhea following the neighbor's barbecue, the jar of mayonnaise that we talked about. You control the source, you control the outbreak, no person-to-person spread. A common source also could be a continuing outbreak if the source is there but continues over a longer time. In the previous slide, we assumed that the source is controlled and the epidemic dies out. What if the source is not controlled? It is continuing. It continues to be there. Still, there is no person-to-person transmission, but everybody that comes in contact with the source or with the reservoir gets infected. So you have an abrupt beginning. This is the exposure, begins, and continues over time until here where it ends. You have an abrupt beginning, and then you see a number of cases that is, more or less stable over time. And then a bit after the exposure ends, you start seeing a decrease, and then the outbreak dies out. Many people are exposed simultaneously rather than transmission from one case to another. So some people get exposed here, some people get exposed here, some people get exposed here, but there is no person-to-person transmission. Example for this is a contaminated water supply that doesn't get fixed. So you have a water pipe that gets contaminated by sewage water. And over a month period of time, people are getting sick because of that. There is no person-to-person transmission, but this is a continuing common source, continuing outbreak because the source of the outbreak is still there. Until it gets fixed, the outbreak will continue. So we saw a point outbreak where there is one exposure. We saw a continuing outbreak where there is persistent exposure. And then there is common source and intermittent outbreak where there is intermittent exposure. The source is still there, but it's not accessed, or it is not, the people don't have access to it or exposure to it all the time. It could be seasonal or weather related. Okay? So for example, every time the sewage water floods, it contaminates the water. And then it recesses during the summertime, and the outbreak goes away. And then during the winter, it floods again, it contaminates the water. And so this is an intermittent outbreak, okay, but a common source. Another example is a contaminated blood product. So if someone has infection and they donate blood, and they donate it to, they take several units out of it. Every time a person receives blood from a contaminated source, they will get the disease. But if they don't get exposed, they will not get the disease. Same thing with a contaminated contact lens solution or tattoo ink or the flood example that I gave. So this is so these what we have spoken about so far are the common source outbreak. Point outbreak, continuous outbreak, outbreak, and intermittent outbreak. All of them are common source. What happens when you have a person-to-person spread? How does the epidemic curve looks like? So with person-to-person spread, you can have a limited outbreak, meaning you have a single case here that gets the infection. They infect other people within the incubation period, and then you have some cases, and that's it. So it means that one index case infects a few people, and then the outbreak dies out. Okay? Point source, one point source, and then you have secondary transmission, because this is the index case, and this is when the transmission happens during the incubation period, and you see the secondary sources. The outbreak wanes when infected people no longer transmit infection to other susceptible people. So an example of that would be a returning traveler. Someone returns from travel, he or she infects, having infectious diarrhea, he or she infects the people in the household, they get sick, they don't infect other people, and that's it. Or someone, a child goes to school with head lice, and then in the classroom, people get the infection and they get the head lice. But the school automatically recognizes it and they send everybody home, and the outbreak dies away. So you don't have further transmission. It's person-to-person spread, but a limited outbreak. That's not what is happening right now. What is happening right now is person-to-person spread with propagated outbreak. It begins like an infection from an index case, like this, and you have a small number of cases, but then these cases will infect others, and these cases will infect others. And what we see is successively taller peaks of infection. So one case, a few cases, more cases occurring, because there is a propagated spread and every person is behaving like a source for other cases. The epidemic continues until remaining number of susceptible individuals declines, meaning you have herd immunity, or until intervention measures take effect, such as shelter in place, go home, stay at home, etc., or if you have a vaccine. An example, classical example, is influenza or the COVID-19 that we are experiencing right now. This is what the epidemic curve will look like for COVID-19. Let's go back to the example that we have on our hands, and this is what an epidemic curve looks like. It looks like the first one. It looks like the first example that we saw, a point source, okay, with a single exposure. Now, the next step in the outbreak investigation is to develop a hypothesis, because you need to have a hypothesis about how the infection has spread. Hypothesis about the etiologic agent, what are the risk factors, what is the mode of transmission, etc. How do we generate a hypothesis? By doing interviews, by talking to people. We collect data about demographics, we collect data about onset, duration and severity of symptoms, complete food history in the last 7 days, water exposure in the last 7 days, exposure to other ill persons, children in daycare, farm animals. Some of the outbreaks have been traced back to farm animals. Travel outside the immediate area. So they did interviews and they collected information about all of this. And then they did what we call line listing. This is an example of line listing. It's not particularly for this example, but just to tell you what a line listing is. A line listing is what the name tells you. It lists, each line lists a particular patient. And if you remember, we said we can describe the data based on time with the epidemic curve, based on place with the spot maps, and based on person. This is one way of describing the data based on person with the line listing. So the nice thing about line listing is that you can eyeball the data, you can look at it, and you can, figure out what is common. So in this case, most of the people will have everybody has abdominal pain. Most of them had fever and diarrhea. Not all of them had vomiting. Many of them were males, etc. So you can get an idea about the information or the clinical features from the line listing. Now, as the number of cases increases, the line listing becomes difficult to interpret and it's no longer recommended. So you do a line listing whenever you have a limited number of cases. So after they did the line listing and the interviews, they found that there has been no uniform attendance at any common event, no big barbecue, no big picnic, etc. And the onset of symptoms extends over 1 month. Factors present in over 50% of cases, being female, eating lettuce, and eating alfalfa sprouts. More than 50% of cases were female, and more than 50% had consumed lettuce and alfalfa sprouts. So now you start narrowing down your risk factors and narrowing down your the possible origin of the epidemic. So then the next step is to evaluate the hypothesis. When we evaluate the hypothesis, if my hypothesis is people who eat lettuce are at risk for infection, so every additional case and epidemiological evidence should be consistent with the initial hypothesis. If I do more and more interviews and then I start finding cases in people who did not eat lettuce, then my hypothesis fails. So we need to make sure that the hypothesis stands with additional data. So from the previous slide, you can have 3 hypotheses. My hypothesis is that only females acquire the infection. The second hypothesis is lettuce, and the third hypothesis is consuming alfalfa sprouts. Now, with females, not the epidemiological evidence is not consistent with that, because you have also some males that are infected, and you do not have really a genetic or a biologic explanation for this hypothesis, so it drops. So you're left with the lettuce and the alfalfa sprouts. So what you go and do a case control study, meaning you look at cases and you look at controls. Controls are going to be age and sex matched, but they did not have the disease in question. So the cases are people who had the disease, and the controls are people who did not have the disease. And you collect the same information from the cases and the controls. So when they did that, they found that in the cases, 56% had consumed alfalfa sprouts, but only 7% of people who did not have the disease consumed the alfalfa sprouts, resulting in an odds ratio of 25, meaning that patients who consumed alfalfa sprouts were 25 times more likely to develop the illness. And no other food item was significantly associated with the illness. So now your hypothesis about lettuce drops, and the hypothesis now is about alfalfa sprouts, and this was the one that was documented and verified by the case control study. So now you do a traceback study to find out where the contamination for this alfalfa sprout occurs. Is it at the restaurant, at the grocery store, etc.? So they found that people ate at various restaurants and purchased them from various grocery stores, from various distributors, but then they were traced back to the Idaho seed lot. Most of them were traced back to the Idaho seed lot, meaning that there could be a contamination over there. And this is what was done also. A traceback study was done with the COVID pandemic, and they did a traceback study until they reached the wet market in Wuhan. Okay, and this is what a traceback study is. So then what you do next is to use the information that you have to stop the current epidemic. You want to establish measures that would prevent similar outbreaks in the future. And you want to do this as soon as possible. So for example, with the COVID-19, they shut down the wet market immediately. And they said that you can no longer have wild animals in the wet markets in order to prevent similar outbreaks from happening in the future. Okay? And you do these as soon as possible. So in this particular example, they removed all the remaining seeds and sprouts from the market. They pulled them from the market to stop the current outbreak. They also went to the producers and to the farmers to make sure that they follow strict guidelines during growing, harvesting, and packing in order to prevent future outbreaks from occurring. So to identify and eliminate all sources of contamination, and they removed the sprouts from the markets for human consumption until their safety can be assured. So now that you have done all of this, you identified the cases, you don't just pack up and go home. You have to stay on the field to make sure to monitor for additional cases, because you want to know whether your measures have worked, whether you have stopped the transmission, whether there are cases that are still popping up. So you monitor for additional cases and you evaluate the effectiveness of the prevention and control measures. And then the last step in the outbreak investigation is to communicate the findings. Every day now we have a daily situation report with COVID, telling us how many cases there are, what are the testing procedures, etc. So it's very important to do daily reports, to do summary reports, to give feedback to the relevant authorities at the local level, the national level, and the international level in order to institute policies so that this doesn't happen again. And it's very important also to communicate with the media in order to alleviate the fear of people whenever you have an outbreak or an epidemic. So in this case, they communicated the findings between public health officials and seed growers, and they did public television and radio announcements saying that we have pulled the seeds, the contaminated seeds from the market, and you will not have exposure anymore, and we will no longer put them on the market back unless we are sure that they are safe. So in conclusion, these are the steps of outbreak investigation, the 10 steps of outbreak investigation. It is important to apply the multi-step approach. It is also important to apply new lab techniques such as PFGE in order to identify new strains of organisms. It's very important to have disease reporting. So if those 4 doctors didn't report the disease early, you could have had many, many more cases before the outbreak was recognized. So it's very important to report the disease very early on in order to limit the spread of the infection. And it's very important to have flexibility of hypothesis generation, because as we said, we are learning something new about a particular disease. So you have a new vehicle for the transmission of E. coli 0157H7, which are the sprouts that have been contaminated in the seed lot. Okay? And this is the end of my presentation. If you have any questions, please email me and I'll be happy to answer. Thank you and good luck.